We're just waiting for the doctors to come. We are here to shoot our very last episode on counterfeits in the health sector. I am right now sitting on a bed in the children's ward here in Mulago Hospital. This is a ward that treats children that is 0 to 18 years who have got hematology, oncology issues, blood disease, cancer disease, and I have been fortunate enough to find a lady here by the name of Fatina Namuyonga. She is Fatina Namuyonga of our Mbale. She's from Manafa district. She informs me that she has a sick child here. Fatina, oja kwogerako eri abakuwuliriza abakulaba eno program eyagala kumanyisa bantu abatulaba obuzibu obuli wano mu balwadde ba kansa n'omusaayi, naye nga program ekwata nnyo ku bintu ebyokufera, ebintu ebiri fake ebijjanga bitulwaza. So ova Manafa district obadde wano kumala bbanga ki?
Natandika obujjanjabi mu mwezi gwokusatu.
Kitula ku ddoboozi. Natandika
obujjanjabi mu mwezi gwokusatu.
Wajja wano nga ni mulwadde?
Nga Shifura mulwadde.
Yali alwadde ki?
Yali azimbye olubuto nga lunene.
Yali azimbye olubuto. That is common with the swelling of the stomach. Is common with the Burkitt's lymphoma. So this is abdominal Burkitt's lymphoma. Dr. Kuku told us that a lot of it is caused by persistent failure to treat malaria. And, so watuuka wano bakolako wafuna surgery?
Kati bwe natuuka wano abasawo bajja ne batukebera. Omusawo n'ajja n'akola kinaba nga amukubayo akayiso ku lubuto olwo.
Yongeza ku ddoboozi.
Omusawo yajja n'amukuba akayiso ku lubuto. Kati n'agenda n'akomawo n'aŋŋamba Shifura ekirwadde kye nkizudde. Ne mubuuza musawo kirwadde ki? N'aŋŋamba Shifura yafuna ensannyalavu ne zigenda ne zidda mu lubuto ne lutandika okuzimba. Naye kati ekyo ekizimba twagenze okukebera ne tusanga nga kyafuna dda kansa.
Kakati ndaba olina n'omwana omulala, ono naye mulwadde?
Nedda, nali sina gwe mulekera ne nzija naye.
Ona abaana babiri?
Nina abaana 4.
Bali abalala ani abalabikira?
Waliwo omulala abeera eno Kampala abeera mu Compassion, omulala ali eka ewaka.
Ali eka waka. Kakati wano e Mulago wooli obujjanjabi buli butya?
Kale bambi obujjanjabi bwe buli kubanza enfunyeewo enjawulo. Nina essanyu lingi ku basajja, omwana teyajja bw'atyo, naye kati ndaba embeera ze twagiramu bambi yakyukako.
Yakyukako?
Teyalinga bwe twajja.
Oteeka okuba osasudde ssente nnyingi?
Sijja kulimba nti nze natoolako wadde 10.
Waliwo abagamba nti e Mulago teriyo ddagala, gavumenti teteekamu ssente, naye gwe ekyo kigambako ki?
Nze ŋŋamba nti bateekamu kubanza ayogera kennyini sinatoolako wadde 10 wano.
Ate ng'omazeewo emyezi ng'ena?
Naye nga sirina ssente zensasulayo, ze ndaba bulabi nga batujjanjaba.
Okulya n'okulya mulya wano?
Okulya aba gavumenti batuwaako emmere, naye kati engeri nga bw'obeera n'omulwadde ayinza okuba nga alinawo kayagala amangu, oba olinawo nga ku ssente n'omugula, naye nga bwe batewali n'otukuma ne tulinda eyo.
Kati abantu e Manafa bamanyi nti oli wano?
Bamanyi nti ndi wano mu ddwaliro.
Bakuweereza obuyambi?
Tebalina kye balina kubanga taata wange yandibadde ampa naye yafa. Kati
eno programu kulwanyisa fake ebicupuli ebikozesebwa kazibeere ensigo zemusimba mu nnimiro, ebizigo bye mukozesa. Wali ofunyeko experience yonna n'ebintu ebiri fake?
Oba bitya awo sikutegedde bulungi.
Noŋŋamba ebintu ebiri fake oba akasimu akali fake nga tekakola, oba ebizigo n'ogula ekintu nekyanonekerawo?
Bibeerayo.
Nga ki?
Oyinza okuba n'esimu bwetyo neeyonooneka, oba n'obeerayo n'ekyokulya nga tekisaana kuliibwawo ebityo.
Kati bannayuganda bagwira mulanga ki ku bintu ebyo ebiri fake? Bakole batya?
Tubadde tugamba nti bandibadde bakyusaamuko.
Bakole batya?
Batuyambe tuleme okuba nga tubikozesa.
Ate yo gavumenti okigamba ki
Bangi
ku bya fake? Kuba bingi biyitiridde Rwanda.
era ne gavumenti naye njikubiriza omulanga nti naye yandibadde era etuyamba kuba ffe tubikozesa nga tetumanyi.
Okay, abeeko bagamba oti osuubira kuddayo ddi?
Simanyi wabula oba tujja kgenda enkya kuba omusawo yagambyeko mbu tulinze butafaali bwe bunaaba obulungi bayinza otusiibulako enkya ne tugenda tumala wiiki emu ne tukomawo.
Okay, webale kwogerako naffe. Omwana tetusobodde kwogera naye. Ayogera
naye tamanyi Luganda.
Tamanyi Luganda. Yeebase. Webale kwogerako naffe. Tusabire tusobole okusuka obulungi muwona, tusobole okuddayo mukole. Kale webale. We have another health caregiver here, Jaria Nakito. She's from Wobulenzi, one of the patients in the hematology ward here at the at Mulago Hospital. Jaria, you are welcome to the League of the Genuine.
Thank you.
Jaria, you have a patient here. Can you tell us what is the problem with your daughter?
This kid has leukemia.
Leukemia. She has been here for how long?
We are going to make 5 years.
5 years?
We have made them. We started in 2016, it was May.
You came here in 2016?
May. So we have made it.
And when you came, what condition was she in?
She was feeling pain in the legs. She was feeling headache. She had diabetes at first. So when we came, it was the reason for coming here. So they made tests and they found her with leukemia. Did
the doctors tell you the cause of leukemia?
I don't really know, and I don't remember since it is a very long time. But for me, what I know is over the environment which we live in, or maybe sometimes I think it's hereditary. But
we have been, we saw somewhere in the statistics that a lot of the cancer is in Buganda here, central region. Do you think it is maybe the food we eat, the lifestyle?
I can't tell.
You can't tell. But why have you spent so long here? Because we've seen some people, they get treated for a few months, they go.
They get treated and go, but sometimes, even for a long time, after finishing their treatment, most of them come back. Sometimes if they treat cancer, if you are not lucky enough, it comes back. So most of our friends who are here with, they finished their treatment and they did not come back. But for us, when we finished, they gave us 2.5 years. So we came for all those years. But when we finished, it was like 1 week. It was like 1 week after treatment of 2.5 years. It came back. She got an attack, admitted, and they make tests. They told me the cancer has come back. So,
do you get blood transfusion? Do they change?
At first, we were getting blood transfusion, but now...
Is there blood here in Mulago?
Definitely, it is there.
Do you pay for the blood?
We don't pay.
Do you pay for the medicine?
No.
Do you pay for the food?
We don't pay.
But some people think government, that Mulago has nothing.
They are talking out of ignorance. They don't pay. I remember one day when this girl sometimes she gets diabetes. So she was supposed to be on 4 drips per day. They gave me all the drips for 1 month to take them home. I used to get a medical worker from my place and I put on my girl.
So, Jerry, how has this affected you as a mother, as a person? You don't work. How is your life?
I don't work. I have a lot of problems. I have other kids. This one is the elder. For instance, it was over the day before, yesterday. She got an attack at the middle of the night. It was like 6. She was unconscious. I left the other ones, and when for them they are too young, I left them at home. Sometimes they fail to go to school because I'm not there. It is terrible.
Oh my God, sorry about that. So, this program here, we are trying to help people understand the challenges we have in treatment. There are a lot of fake medicines around, fake things. What is your experience with the fake products or services?
I don't have an experience in those fake medicines because for me, when I buy things, I usually check on that mark of UNBS. So I don't buy I don't just buy things anyhow.
So you advise people to check UNBS?
And then the expiry date. I advise them to check the UNBS
expiry date, UNBS.
Even the expiry date, because most of them buy things when they're already expired.
But we have a problem in Uganda. We like cheap things. What's your message to Ugandans?
What I would like to tell them, they should know that cheap things are expensive. That's all I can tell them.
Your message to mothers who have sick children. What is your message?
They should know that it is God who made them to be like that. They should handle their cross as God has given them. No, what I should tell them, they should treat their kids because nobody cries forever and nobody loves forever. So they have to carry their cross. That's what I can tell them.
Okay, we are going to stay praying for you and hope that God's healing hand can touch you and heal your daughter. We thank you so much for being so kind to talk to us, and we hope that your daughter can recover soon. Welcome again. Welcome to another episode of the League of the Genuine. This is the only show on the planet that talks about fake services, fake products, counterfeits, substandards. You know, those who have been with us for the last 6 weeks, we have been tackling the issue of counterfeits and cancer, counterfeits and our health. And we would like to sum up that discussion on counterfeits in the health sector with a discussion we have right now with 2 eminent doctors. We are right here in Mulago Hospital. This is one of the oldest hospitals in the country. It's more than 100 years old. But we are in the ward. We're going to find out what ward we are in at the moment. I have on my right Dr. Deogratious Manube. Dr. Deogratious Manube, you are welcome to the show.
Thank you, Fred, and I'm very happy to be part of the show.
Dr. Deogratious is the president of the Uganda Paediatric Association. That's how you pronounce it, Paediatric.
Yes.
Paediatric Association.
The Pediatric Association.
Pediatric Association. Pediatricians deal with children.
Yes, that is true.
That is from the age of 0 to 20?
From the age of 0 to 18.
The age of 0 to 18. He's a consultant pediatrician at Mulago National Referral Hospital, where we are. Doctor, where are we sitting at the moment?
So Fred, today we're sitting in the children's ward, Jellyf ward, It is named after one of our prominent professors who trained a good number of pediatricians long time ago.
The children's ward.
Yes.
So what do you treat here in this ward?
So in this ward, it is divided into two groups. One, we have the hematology and oncology.
What is hematology?
Hematology are blood conditions, and oncology are cancer conditions. And also within the ward, we have those children who have cardiac problems and also pulmonary or chest problems. So that is the jelly ward.
So right here in Mulago, we are joined with his colleague, Dr. Peter Wasswa. Dr. Peter Wasswa, you are welcome.
Thank you, Fred.
You're looking so nice in white.
Thank you, Fred.
Could you probably tell us why you wear white, not red or blue?
Fred, I wish I knew the answer. I think it's partly historical that white is a color that's associated with cleanliness. And if you have health, you want health to be associated with hygiene. Hygiene leads to, clean, and probably cleanliness results in better health. I suppose that's my guess as to why we're wearing white.
We were told by Dr. Okuku that there are some fake doctors around. They are moving around the Cancer Institute wearing white. So isn't it easier for somebody to wear white and masquerade as a doctor?
You're absolutely right. Many people have masqueraded as doctors or other professionals by wearing outfits that are similar to those professions. So in addition to somebody wearing white, you should be able to have some kind of identification on them so you can tell who they are. So just wearing the outfit shouldn't describe the person. So it's important
Your
that
white
people are white.
Your white has Baylor College of Medicine.
Yes.
So are we in Baylor College of Medicine?
No, Fred, we are in Mulago as Dr. My colleague has mentioned, Dr. Manube.
So you're wearing the wrong coat.
Well, I'm not. I'll tell you why. So I'm employed by Baylor College of Medicine, which is based in the United States, in Texas. And I'm the director of the Global Hope Program. Global Hope Program is part of Baylor College of Medicine, Texas Children's Hospitals, and it's an organization that works in several countries, including ours. And the main focus of Baylor College of Medicine, Global Hope, is capacity building. Capacity building in the area of pediatrics, of childhood, cancer disorders, as well as blood disorders. That's the main focus. And why is capacity building important? It's important because when we look at how well our children do who have cancer, we know that traditionally we've had very poor outcomes with most children with blood cancer and hematology, so blood cancers, other cancers, and sickle cell and other blood disorders succumbing to these diseases. So I will tell you that, for example, less than 10% of children with cancer survive in the poorest of countries, yet we know that the advances in science and practice have resulted in cure rates of over 80% of cancer for children in developed countries. So the reasons so necessarily we need to close that gap. And one of the reasons why that disparity exists is because of a paucity of trained personnel, lack of infrastructure, lack of access to medications and diagnostics. And that's why Global Hope is here in partnership with Mulago to try to improve the outcomes of children.
Wow, great. Dr. Wasswa, you're also an assistant professor. Correct. So you are helping to teach new doctors.
Correct.
New oncologists. How is the situation standing now? Are we teaching enough people in this area?
We don't have enough hematologists, oncologists in the country. To give you an example, 10 years ago, well, not even 10 years ago, I'll say 5 years ago, before we started, there was one pediatric hematologist oncologist in the country. And that was joined by another one who came in to help start the program. But as we speak now, we've got a training program in place for the last 5 years, and we've had over 10 pediatricians trained as specialists in pediatric hematology, oncology. So I would say that the capacity has more than doubled over the last 5 years. And in fact, not only has it doubled, but also spread out. Because now in Mbarara, for example, you have two pediatric hematologists, oncologists. So children in the west of Uganda can be treated there. But also the ones in Mulago, they're more than the way they used to be. But also in East Africa in general, we've trained 4 pediatric hematologist oncologists that are out working in Kenya and Tanzania. So it's improving the capacity here within Mulago, in the country, but also regionally.
Dr. Deogratious, you heard your colleague talking about capacity.
Yes, Fred.
And this is the National Regional Referral Hospital, meaning it's the biggest in the country. And if we are talking about capacity, just look in the ward where we are. This is the ward that deals with the cancer cases for children, blood cancer cases for children. But I can see we don't have more than 30, 40 beds. Where is the problem? Is this sufficient capacity? Is it that we have so few cases? Or are we having a challenge with the bed capacity, for example? Not only doctor capacity, but also bed capacity.
So thank you, Fred. It's very interesting that you have been able to observe the numbers. So what is interesting about our program is that we have been able to combine both inpatient and outpatient care into the program. There were times when if you were on cancer treatment, you would have to be an inpatient, meaning that you could possibly see 4 times the number of people here. But we have developed the program in such a way that only those who require inpatient care or additional support are the ones who are admitted. So some of the people you see around here are actually here for a few days and they'll be going home, and then we'll be following them up in care in the outpatient setting. So it's a new idea that we have tried to bring on board. It's not new for the general cancer care, but it's something that's new for our care within the country.
How many cancer cases for children are reported here every year? And is it increasing or reducing?
I would want to say that it is increasing. And it's increasing because we're able to identify more. So if I go back over the last year or so, we had over 200 cases that were reported in the year of COVID. And right now, as I speak, we are close to about over 100 in this current year. So when you train more people to be able to know the conditions, you tend to pick up more and more diseases. And what is also interesting to note is that quite a number of people who used to have malaria-like illnesses are actually people who possibly could have been suffering from cancers. So it's something that has enabled us to learn more, been able to allow us to identify more children. And then, of course, like you mentioned, is this space enough? I would answer straight away, no. This hospital was built over 100 years ago to cater for a small population of people. And that's why you see that there's a drive to have more space for all the services. And not that the population is only growing, but we also have the ability to test and detect more and more of these conditions. So if you asked me what exactly is going on, for example, with cancer, do we have more? I would say no. I would say we're able to detect more compared to the past. Thank you.
Okay, this question will go to both of you. First with the Deogratious. What do you think are the factors that are causing an increase in the cancer cases among children? Is it something that is internal? Is it external? Is it with the environment? Is it a parenting problem? First, you with the Deogratious.
So, Fred, very interesting question. And you know, the interesting answer is that we don't know. Cancer is one of those diseases where only about 10% of the causes of cancer might be known. The other 90% you might have no idea of why the cancer has come. So in that small group of people, there are some associations that you would be able to say that, oh, this is a child who was born with this type of condition. So because they have this condition, they're at risk of getting cancer. Most times it is sporadic, meaning that it just happens without any explanation. And that is the truth about cancer care. There are many myths you will see. If you go on Google and type causes of cancer, they will tell you if you live under a high voltage line, or if you drink too much soda, or if you take too much
sugar.
Of this. If you take too little of this, you are at risk of cancer. We actually don't know. A lot of research has gone to try to identify, but very few cases. Very few genes that are known. But when you test randomly the whole population, you may not find the people who get cancer having those genes. So it is what we call a sporadic event. It happens.
Dr. Wasswa, your colleague has said he's not 100% sure why we are having more children getting cancer. You happen to have an association with the Texas Children's Hospital, Baylor School of Medicine. So you're associated with the Americans who are supposed to be leaders in healthcare. What is your experience from that side of the world that you think you can inform our viewers why the increase in cancer cases among children, among adults? What is driving this?
So as Dr. Manube said, I reiterate that even in the high-income countries, for most children, even for most adults with cancer, the cause is unknown. Now, it's very interesting about exposures. You know, there's some cancers we know, for example, in adults, that if you smoke, your chance of getting lung cancer is higher. If you drink alcohol, perhaps your risk of getting liver cancer is higher, and certain types of cancer. But what we know is that for many of those exposures, it will take a long time of you being exposed to that particular event, to that particular cause for you to develop cancer. For children, most of them have lived for a short time. So they haven't lived long enough for an exposure to actually result into cancer. So for most children, as we said, there's some kind of genetic event that for some reason happens, and we don't know why that genetic event happens, okay? That results into cancer. As you said, there's a lot of work being done, but particularly where the family history of cancer, where, for example, more than one member of the family, the close family, develop cancer. Or, for example, in situations where a father develops cancer at a young age and their offspring get cancer. But for the most part, we don't know. There are certain cancers for which genetic changes have been known to occur and run in families. For example, some eye cancers, we know that they run in families. And in fact, those ones are screened and children are monitored to see if they develop cancer. So that if they develop cancer, that can be treated early, because when they are treated early, then the chances of cure are higher. There are also certain genetic conditions that we all know that can cause cancer in children, or predisposed to cancer in children. And such patients, such children, such families are followed through to try to monitor them for when they develop cancer. But just like here, the vast majority of patients...
So is that why in this ward here, because we were asking around some of the parents, the mothers with their children, a lot of the cases here are blood cancer. Why would a small child, 8 years, 5 years, 10 years, have blood cancer? I thought these were things associated with maybe lifestyle or engaging in certain... Why would children get blood cancer?
The most common type of cancer in children all over the world is blood cancer. And in fact...
What causes it?
Blood cancer, for the vast majority of children, we don't know what causes it. They may be in a small minority of patients. For example, we know that children who have got Down syndrome...
What's Down syndrome?
Down syndrome are what the people used to call Mongols, okay? It's not what the people used to call Mongols in the past. These are children who are born with an extra chromosome. You know the chromosomes that the building batics of the genetic material? So they have an extra chromosome extra chromosome 21. You always have 2 pairs of chromosomes, okay? But you have a third chromosome. So those children tend to be born, and they tend to have look like a bit like Orientals, okay? They have basically a wide-spaced nose. They have sometimes slit eyes. They may have a flat nose. They tend to be a bit floppy. Sometimes they have cardiac heart lesions. Okay, so those are kind of kids. You see them around, and they tend to be very happy children, but they tend to have a lot of other health problems. We know that a certain proportion of them do develop cancer. Okay, and we know that they have a genetic condition, again, genetic change within them that predisposes them to develop that type of leukemia. But that's a minority of children. Okay. For example, I would say that for most of our patients, we treat over, maybe 60 patients with leukemia a year. Some years we get a child with Down syndrome, sometimes we don't. So I would say the vast majority of the children that we see here, we still don't know. If we knew, I think that would be that will be a gold mine. That will be fantastic, because then we would work towards preventing cancers developing. As it is, it's still work in progress, I think. I think our understanding of cancer is still evolving, and who knows, maybe in 100 years people look back and say, hey, those people who lived in that century, we were so ignorant. Now we know so much better about it. So at the moment we don't know.
You don't know. But for us here on the League of the Genuine, we have some clues. I want to suggest to you, Dr. Deogratious, that there might be a connection actually between fake products, consumption of fake products and services with this upsurge of disease. For example, I am seeing your map here. This is the cancer distribution map for Uganda by sub-region. And according to your map, you show that the central region, actually you show that Kampala and the central region have an average of about 20% or slightly less in the incidence of cancer. Now, I am sure you have heard the Uganda National Bureau of Standards said that most of the products we consume in the supermarkets, more than 54%, are fake. Is it a coincidence that most of the urbanization is in this very area where there are more cancer cases? Don't you think it makes a case for a study to see why the place which has more counterfeits is registering more cancer cases as well? Don't you see a connection from your own map here?
Yes, so Fred, it's very interesting that you've observed that unique occurrence. But what I would want to highlight is that there are some products which are maybe responsible for some cancers, right? But you are not sure. I'll give an example of skin cancer. Skin cancer is one of those cancers where if you destroy the layer of your skin, you expose it to the external environment, and there may be changes. So some creams, some things that may not be put in the right proportions.
Skin lightening creams, can you talk about them? Is that what you're talking about?
It could be skin lightening, it could be skin darkening. But the fact that you are changing the natural environment of your skin puts you at risk of a kind of change.
Doctor, while you're on that, the ladies who are bleaching, what are you telling them? Is it okay? Is it not okay? Are they exposing themselves to cancer?
I would say a lady who is bleaching is not doing good justice to her skin. They're putting themselves at risk of even first things first, not even cancers, but infections. Because your skin is a natural protector for your body. It is more than 80% in terms of the organ size. So when you damage your skin, the normal flora, or what we say, the bacteria that keeps your skin safe, are removed, so you expose yourself to infection.
But some people think this black skin is bad. They prefer the white one. What's wrong with our skin?
My skin looks very well. I have no problem with my skin, Fred. So it is a misconception. I'll give you an example of hair. Let's go away from skin. Someone says if your hair is straight and long, you are beautiful. If you have nappy hair or curly hair, you are ugly. I don't know where that came from. It's the same way that if your skin is dark, you are not beautiful. But I have a lot of friends from South Sudan. The darker you are, the more beautiful you are.
Wow.
Yes, and that is something that's quite interesting. So it is our perception.
So our hair as Africans, it looks up to the sky, to the sun. The other people have hair which looks in the ground. This is somebody saying that, and therefore maybe there is something special about our hair.
Most likely there could be, but the association with fake products or chemicals, because if you look at the incidence of cancers in places where there have been chemical exposures, if you go way back to the nuclear bombs, there was that clear association of a rise in certain things. But the exposure then was so high that it could explain why there was this genetic mutation or a change in your genes. Now we don't have that much exposure. So you're not really sure whether it is what came first. Was it the cancer or was it the exposure? So those are things like Dr. Peter had said, we shall keep investigating. And we have an opportunity because now we're able to document more and learn more. In our program, we are looking at clinical characteristics of cancers. So we are storing samples to be able to help us understand what took place in your body at that time. We may not be able to test it now, but in the future, 5, 10 years from now, there may be some exotic techniques which would enable us to say that, oh, guess what? Dr. Dewa at that time he had leukemia, had this genetic change in chromosome number this that made him at risk. But right now, we are not sure.
Talking about exotic, and I'll come to Dr. Wasswa as well. These days, it is considered exotic, it's considered a good life. If you give your children fast foods, you take them to all these eateries and talk about fast foods and children and the diseases children are getting these days. Do you see a connection? Plus obesity.
So they are what we call diseases of lifestyle.
Yes.
So
fast food in particular. Is it fake?
Fast food is a misnomer because the idea of what is fast might not be equal to what
it is cooked in 2 minutes, 3 minutes. It's not like our luombo, which you will cook and wait for half the day it's cooking. So 3 minutes you have food.
So for example, if I want a good portion of matoke, it means they should have started cooking from early in the morning for it to get ready. However, if I want a sausage, that can be dipped into hot oil, fried quickly, and I am eating it within a short time. So the diseases of lifestyle, the biggest thing are obesity, which affects our children. And they're the ones that increase what you call non-communicable diseases.
So does obesity bring cancer? Does it bring diabetes in children?
Obesity can bring diabetes. It is not a clear association with cancer. But with diabetes, heart diseases, that is a clear association. Lack of exercise can lead to quite a number of the non-communicable diseases. And also within this big group of non-communicable diseases, we have the cancers. They also fit into it because I cannot touch you and you get cancer. I cannot touch you and you get
So that's non-communicable.
Non-communicable. So you find that the lifestyle does play a role in a bigger proportion of non-communicable diseases, but a smaller proportion when it comes to cancers.
So, Dr. Wasswa,
Yes.
for you have been with the Americans. You guys brought for us fast foods here. And we are getting sick. He says we get diabetes. Can you take some blame? Is it something that you feel sorry about? Even the Americans are avoiding the fast foods now.
I take blame from who? For who?
Because you are trained there.
Actually, I was trained here, I would say.
You are trained here.
Yeah, I was trained here, and then after my basic training, I sought for training that wasn't available in this country at that time. That's why I went to Europe, I went to the United Kingdom, and trained, and subsequently, worked for the institution I worked for, which is Baylor College of Medicine, Texas Children's Hospital, which is based in the United States. But I would say they are trained in adopting things that come from the West. It's something that has happened over generations, over a long time. And part of it is, of course, the exposure. It's now, we had the CNN effect. Now, of course, we have all these social media and everything else. What trends in terms of music, in terms of food, in terms of style, fashion, and food is part of what has caught on. And part of the reason, of course, is one, the foods are fairly tasty. Why? They've got lots of salt, they've got lots of oils, and we know that tasty, oily things, much as they're not healthy to us, actually taste nice. And
so you're encouraging the viewer to go for the jump?
I'm not. I'm explaining why I think it's catching on. Okay, but actually we're eating poison in some ways. Okay, so a normal diet should be a balanced diet. Okay, it should be encompassing fruits, vegetables, carbohydrates and proteins in the right ratios. But it so happens that because of convenience and because of what tastes nice, that increasingly young people, now even adults, have actually picked up on these kind of styles. So not everything that comes from the West is necessarily the best thing to actually adopt. And actually people have realized, even in the West, it took a long time to realize, for example, coming out from that smoking causes harm. People realized that in the 60s, that smoking causes lung cancer. And that's why people backed off. They later realized it causes heart disease, and they backed off. So they also realized that actually a lot of what you are in the future, communicable disease associated with what you eat. So essentially, that realization led people to actually back off. Now, coincidentally in the West, actually the disease of lifestyle, which are related to that, actually found in people who are less wealthy. Because actually these fast foods in the West now are the cheaper ones. The healthy foods, the green vegetables, are the ones which tend to be more expensive. So actually the disease of heart disease, smoking, and other issues with that actually tend to be more prevalent among people who are poorer. Okay, the reverse is true here. You have to remember that a few years ago, having a pot belly was a mark of success.
Up to now it is, yes.
It is, okay? But that's because traditionally we have very few people with fat bellies, apart from those who are prominent. People who are actually starving. It was difficult food for those ones who are comfortable enough to be able to access the food in whatever quantities and whatever time they could. To be able to afford maids so they can't do physical work. To drive a car so they can't walk. To swallow in a chair in an office so they can't turn around and do exercise.
Sedentary lifestyle.
Exactly, sedentary lifestyle. Exactly, that's what has led. And obviously the offsprings have been raised in a fairly sedentary lifestyle, in a fairly environment where they can access food easily and cheaply, relatively cheaply. So all these things work together to create the kind of problems that we face today. However, with the challenge how do we meet that challenge is actually education. Platforms like these ones are the ones which are going to help hopefully educate the population into adopting what is now considered a healthy lifestyle.
Talk about educating. There is a big debate with the modern woman between breast milk and formula milk, the imported one. What should a young child, a baby, be fed on for the first 1 year, first 6 months? Do you recommend breast milk or you recommend the formula?
So the World Health Organization recommends exclusive breastfeeding for 6 months, right?
6 months.
6
for
months
breastfeeding.
Breastfeeding, yeah. A minimum of 4 months, but certainly 6 months is a recommendation. Feeding for longer is also acceptable. That's not a problem. We know that the best food for baby is breast milk.
But we have the modern lady saying, in fact, they don't want to wear bras. They would like their breasts to stand up. So they don't want to breastfeed because they will not look attractive. It is a common practice now.
I think there are several reasons why some women may not choose to breastfeed. And these are
but is it recommended?
So the recommendation is breastfeeding. Not breastfeeding is not recommended except in certain very rare situations. But actually, for the vast majority of women, vast majority of situations, breast milk is what's recommended. Now there are situations where women can't feed. For example, if a mother is sick, if a mother is deceased and they're not present, if, for example, they are mentally, or they've got some other challenges that force them to breastfeed, that's when perhaps formula milk may come in. But actually, when everything is constant, when things are available, and we know that actually children who are breastfed are less likely to have diarrhea illness, respiratory illnesses in childhood. We also know that they're less likely to suffer this disease of lifestyle later on. For example, we know they're less likely to be obese, less likely to suffer diabetes and hypertension. So actually, the payoff may actually be much, much later. The payoff for not breastfeeding or for breastfeeding may actually be much, much later in later life.
Good. Dr. Deogratious, we need to see how to close this. But here in this ward, I can see that it's inpatient, and that means that people are fed here. Is that correct?
Yes.
So we have a big problem. A lot of the food we have on the market is actually fake, it's contaminated. Recently we had an issue with our maize with Kenya, and it was being rejected because it was contaminated with aflatoxins, which you know that have active carcinogens that cause cancer. How is this ward ensuring that the mothers, the babies that are here, are feeding on safe food? Where do you get the safe food from?
Thank you, Fred. So within the Mulago National Referral Hospital operations, we have what we call the Mulago Kitchen, or it is the
Mulago Kitchen.
The Mulago Kitchen.
Is it a mobile kitchen?
It is a stationary kitchen, but it is mobile when it comes to distributing food. So the Mulago Kitchen is responsible for providing meals for patients. They provide them with breakfast, they provide them with lunch, and the head of the kitchen is actually a nutritionist who is able to guide the hospital on what are the best foods that the hospital needs, and is able to also give a balanced diet. So all the people you see around here actually receive meals from the hospital. However, you may have someone who may have their own preference. So if you're someone who does not like porridge, or who does not like kosher and beans, you may buy other types of foods. But the kitchen of Mulago is able to provide meals for everyone within the hospital.
Doctor, you're talking about the kitchen of Mulago. I didn't hear you talking about the garden of Mulago. Do you have your own farm where you grow your tomatoes, your maize, to ensure that there are no unethical practices like spraying the tomato with a pesticide to preserve the shell life? Do you have your own cows where you ensure that they are fed on proper animal feed, or your chicken? Because if you feed the cow with a bad animal feed, it affects the milk, it affects the meat. How do you ensure that what is cooked in your kitchen is genuine? Do you have like a special supplier?
So the hospital goes through the public procurement processes where they have suppliers that provide foods for the hospital. So I would say we go through the legal system of getting suppliers.
The procurement, yes.
Procurement processes. It is interesting if as a hospital we are able to have our own farm. Because when I think about it, there are some other institutions, like even schools, that ensure that they have their own farm to provide food for their pupils or students. It is something that I think if the administration would be allowed to and have the resources, it will be something that will be best done, because you would ensure quality of the foods that we receive.
Okay, so aside from food, how do you ensure quality of the medicine? Because the WHO has given reports for the last 15-20 years saying that life-saving medicines in Africa, 30 to 40, sometimes 50%, life-saving medicines, tuberculosis, HIV, cancer, anti-malarials, are fake, and they are permeating the distribution channel, the hospitals like this. How does Mulago ensure that the people who are already sick and come for treatment here are not made more sick or even killed by fake medicine?
Thank you, Fred. So Mulago Hospital receives its primary distribution of drugs from the National Medical Store. And under the system of the National Medical Store, there are many authorities that ensure that what they receive is good quality. And one of those authorities are the National Drug Authority. So NDA are responsible for ensuring the quality of drugs that come into the country, and the National Medical Store procure from reputable organizations or industries that provide good quality drugs, as have been checked by the National Drug Authority. And I'm sure you are aware that most of the pharmaceuticals that provide drugs to, or medicines as they are called now, to Uganda are visited by NDA, and even some big organizations are able to send their own technical persons to see where these drugs are made. Because in the past, and if I can share, I know there were cases where people would procure drugs from warehouses which actually just have children packing drugs, but they're able to go and use what they call the good manufacturing practices standards to evaluate where our drugs come from. And when they do come in locally, the NDA still takes small proportions of them to test them. As a hospital, we don't have the mandate to test our drugs. We refer any queried drugs to the National Drug Authority to evaluate any drugs which we suspect may have a problem. So that is the system
That's how you do it.
that we rely on.
We have spoken to many doctors on this program, and they have told us that sometimes the drug is genuine, but the handling, the storage, the transportation makes it fake. So how do you stop a visitor coming here to visit a patient and giving medicine? Maybe they have bought it from abroad or from some source. How do you prevent that?
So the first thing that we try and encourage is that the nurses give what they call health educations within the hospital. And they ensure that the drugs that are being given by qualified personnel. There may be cases like you have described that could occur. But then we always pray that our nurses educate, inform, and tell the patients that the drugs we are giving you are drugs that are good, are checked, and they come from the right sources for you to get better. We also realize that when we have cases of where maybe a drug is not working, we're able to report and have samples of that drug taken and tested to see if the drug has the right components. Because in good manufacturing processes, you expect that a drug should have a certain percentage of the active ingredient. Now, some people can say, oh, if the drug comes from China, it is poor quality. If the drug comes from India, it's poor quality. But the question is, that drug that comes from China, that comes from India, when tested, does it have the
Active ingredients
that would allow you to improve in the disease that they are treating you for? It doesn't matter which part of the country or the world it comes from, but what is the quality of that drug?
The active ingredient. Yeah, just to move a bit on the pharmacy side here at Mulago Hospital, we just had Dr. Deogratious saying that most of their medicines are procured through the National Drug Authority, national medical stores. But in fact, here at Mulago, they also have a pharmacy. And we are happy to be joined in this segment by Maega Nanyoga. She's the head pharmacist here at the Hematology and Oncology Children's Ward. We would like, Nanyoga, first of all, welcome to the show.
Thank you.
This show is intended to promote genuine. And I can imagine that you only sell genuine or you only have genuine in the pharmacy here in Mulago. Where do you get your medicines that you give to your patients?
We procure our drugs from a vendor that has been pre-qualified by the program, but we also get about 20% of our drugs from Mulago, and Mulago procures its drugs from national medical stores.
So what steps do you take to ensure that in your supply chain, all the medicines that you give to the people who are already sick do not make them sick again? How do you ensure they are not falsified? How do you ensure they have the right ingredients? How do you ensure the packaging is okay? How do you ensure the storage is okay?
I can guarantee about the storage, but unfortunately when it comes to confirming the quality of the drugs, we rely on our pre-qualified vendors because we assume that it's their responsibility to ensure that their drugs are of quality, and they also rely on the National Drug Authority. So it's an assumption really. We assume that the National Drug Authority performs its job and does all the quality assurance tests at the port of entry when the drugs get into the country.
Do you have here in Mulago a callback system? Because sometimes we've seen in the news that a certain drug was recalled by the manufacturer because it was found to be harmful or to be dangerous. Do you have cases here of a drug is procured, the manufacturer says it's wrong, and you send it back either to the medical stores or to the manufacturer?
Yeah, the entire process starts with the National Drug Authority, which basically notifies all hospitals and pharmacies about the drug that has been recalled. And when that happens, we actually compile all the drugs and send them back to stores. So the stores takes it from there.
So you have, for those viewing, you have any medicine recalls that you can cite in the recent past? This drug was recalled, that drug was recalled, so that if it is still on the market, the people out there should watch out for it.
There is ranitidine is a drug that was actually recalled, I think, early last year.
What is ranitidine?
Ranitidine is a drug that is commonly used in the management of ulcers, and you won't find it anywhere in Mulago because the hospital knows the drug is not safe. So even if you go to stores and you tell them you want ranitidine, you won't find it there. And the information is readily available on the internet. If you go on the National Drug Authority website, that information will be there.
Okay, and lastly, we have a culture or a habit here of self-medication. We have a habit of your child is sick with a fever, you go to the nearest pharmacy or drug shop. What is your comment about that habit? And then also too, what's the difference between a pharmacy and a drug shop? Should we go to a drug shop? Some drug shops sell sugar, and then they also have medicine on the one side. Then some places are purely pharmacy, and they also have cosmetics. Are those right places to go to?
Yes and no. When it comes to what should a drug shop sell, what should a pharmacy sell, all that information is outlined in the regulations. There are certain types of drugs that are not supposed to be in the drug shop. So we expect the National Drug Authority to actually send down its surveillance teams to try and identify which drug shops are selling drugs they're not supposed to sell, basically to ensure the safety of our people. Okay, and when it comes to self-medication, for simple ailments like a headache, I mean, pharmacies might be looked at as a first aid place that you would go to. I have a headache, you want paracetamol, but you should take it from there to go and get healthcare assistance from
a hospital or from a clinic.
Yes.
Are there fake pharmacists in Uganda?
I cannot answer that, unfortunately.
Because some people told us that there are fake doctors roaming around wearing a white gown. How can we tell a genuine pharmacist?
When it comes to the professions, we have professional bodies that ensure that we are actually qualified pharmacists, and we have identification cards. So any reasonable person should take the initiative to find out if that person is actually real. You could ask for the identification, because one of the challenges we also have is that patients in Uganda do not know their rights. According to the patient's charter, a patient has the right to find out about the person who is managing them.
The doctor, the pharmacist, the nurse.
Yeah, the qualification, they have a right to that information.
The source of medicine.
Yeah, definitely. But unfortunately, that is actually quite difficult for the source of medication. Even for you, the person who is selling the medication, it might be difficult for you to tell because you have a lot of parallel
imports.
Yeah. So that's where the problem actually comes from. The supply chain is a huge factor when it comes to counterfeit medication.
Well, I think we need to get back to Dr. Wasswa and Dr. Deogratious, but we needed to have a fill-in there for the pharmacy side. They have a big pharmacy here in Mulago. We have the head pharmacist here who has also spoken to us about the measures on how they are ensuring that they keep out the fake medicines. Thank you so much, man.
Thank you too.
Dr. Wasswa.
Yes.
Again, I'll take you to the American connection. Here in this one, are we using American drugs? Are we using Indian drugs? Are we using Ugandan drugs?
We are using a combination of drugs, well, from a combination of different sources. By and large, the drugs that we procure within the country are drugs that, as you will know, predominantly come from Asia, from India and subcontinent, and sometimes from the Middle East. And then we also get drugs and supplies sometimes from partners that come from different countries, including those in Western Europe and those in North America. Now, Fred, it's very interesting that we're talking about sources of drugs. As if when you go to the market out there, out to the pharmacy, sometimes you are offered with two different price options for a same drug. And you'll be told, this is from India, or this is from Germany, or from UK, or whatever. And
So what should we buy? India, Germany?
So that's where the question of fakes is. And I think one of the reasons why people may not necessarily trust a drug from, from some of the Asian countries is about trust. It's because of sometimes what people perceive as lack of a stringent regulator. For example, a drug going into the United States, for example, you have the Food and Drug Administration, the FDA, which is a really strong regulator, which is well funded, got lots of resources, so it can stamp its authority and prevent drugs from coming into their country. We have some regulation here as well, but of course in third world countries there are some weaknesses we face, and we're working on those. Okay, but I can't really speak for what comes into this country. But we know that many times, for some reasons, drugs have been smuggled into this country. Okay, so you're talking about not just the regulator, but actually how is your customs dealing with the drugs? Okay, how is your security agents, how is the police handling issues with inspection? Okay?
But there are issues with packaging. The packaging can be removed and then they put...
Correct. And there are certain things that are recommended in a way to quite minimize the risk of, for example, having fakes. How do you know, for example, if you have a package, look at the package, is the seal intact? How is the writing on the package? Is the writing on the package, is there grammatical errors? If the grammatical errors are there, those are red flag signs that perhaps something is wrong. Look at
what about packaging. Expiry date? Can a drug have expiry date of 5 years or 7 years? What's the average?
It depends on the drug and what the manufacturer is. So you have to really look at the manufacturer of the drugs. They vary. But there are things you can do to try to avoid having expired drugs. For example, what does the information within the box say, and what does the information on the outside pack say? There may be some inconsistencies, and if you find inconsistencies, those should raise the alarm bells. If you buy a drug so cheap, okay, we like cheap things, we like a good deal, but is it too good to be true? Okay, sometimes you have to think about that. What may be very cheap may actually turn out very expensive.
Give us some examples of fake drugs that are common with treatment of children. Some names, the ones people should look out for, which are commonly faked, where you need to be careful.
I think people should be careful with all drugs. And how do you be careful with all drugs? One, you have to try to purchase the drug from a licensed pharmacy. Okay. Try to get it from a licensed provider, a qualified provider. Try not to self-medicate or self-diagnose, because if you self-medicate, chances are you're going to get drugs and buy them. I'll give an example. That because it's very difficult to get a prescription-only drug in the US or in Western Europe.
Prescription meaning that a doctor, Dr. Deogratious, writes a note for you and you go to a pharmacy. That's prescription.
Correct. Your senior
then there is over-the-counter.
Yes.
Where you can buy without prescription.
Correct. For example, paracetamol, ibuprofen, some painkillers, some contraceptives, you can buy them over the counter. But for prescription-only drugs, they should be only be done on provision of a genuine prescription from a qualified person. However, in Uganda, often it's not the case. No wonder you find people coming from Europe or from wherever, coming here, and when they're going back, they pack malaria tablets, they pack, some antibiotics to take back to their countries, because the rules are such that you can't get hold of these there, because the rules are stringent. Okay, so if you have stringent regulation, then fakes are less likely to abound in that society. But even in those countries, now we have the wide world, the internet. Okay, drugs can be bought online.
Online, yes.
So you have to remember that even drugs you're buying online, there's a higher risk of you buying fakes online, because many scrapulous people out there are doing business on the internet. But there are things you can look out for. For example, does the website have a physical address? Do they have a telephone number? If they don't have that, they have to question themselves. Actually, do they have some kind of presence somewhere, physical presence? And number two, look, who are the people in charge of this? Okay, what's their history? Okay, even their pricing? If the price is very small, then chances are they're faking it. Because as we think of regulation, even the guys who do the fake drugs are also getting smarter and smarter. So one way is actually, the responsibility starts with the individual. make sure that if you get a prescription, it's from a qualified professional. Get the drug from a licensed institution, a pharmacist, or hospital. Question, look at the pack, inspect it. Is it actually the right, what does the, is it the writing, is it appropriate? What does is there inconsistencies? What is it? Is there a broken seal? Those kind of things.
Those are the kind of things. Dr. Deogratious,
Yes.
You heard your colleague saying that sometimes we have gaps here in the regulation. And you are a whole president of the Uganda Paediatricians Association. Would it be right for somebody to blame your association for not pushing for stronger regulation to ensure that we don't have fake or illicit falsified medicines on the market? Is your session doing enough?
So Fred, one of the things that we do is that we also advocate. And advocating for the child automatically brings in medicines. So sometimes you find that there are some hot topics that could come up with regard to regulation that are talked about more compared to others. But overall, the idea is advocating for the children. Are they getting the right drugs at the right time? Are we giving them the right drugs at the right time? Are we preventing wastage or misuse of drugs in the child? Because one thing that we have seen a lot is, if a child is sick, the first thing is that you want to give some form of treatment.
Is that a right practice? A fever in the night at 2, shouldn't we give some paracetamol, there is that, what is it called? To cool
down.
Or you put a piece of cloth?
So the first thing I would say is, if a child is hot at night, a warm bath or a damp cloth bed bath would be the best. Because ideally you should not have all the medicines at home. You should be able to take
What is the
child.
first aid? What is the first aid? You have a child, there is a fever. What is the recommended first aid?
I tell my mothers the first thing that they do is to get a warm cloth and they sponge the child to cool down.
They cool down with a warm cloth?
With a warm cloth.
How does that work? What's the science?
So tepid sponging is the science. I'll use the big term. But what happens is, when you're hot and you use a warm cloth, you don't use a cold cloth, because the cold cloth takes away a lot of the heat. And you don't want the child to be from being too hot to being too cold. So you want to regulate the temperature.
So you increase the heat?
No, you reduce the heat, but not to the extent of making the child cold. Because the false belief is, when you're hot, pour cold water on. So you move from when you're too hot to when you're too cold. You want to maintain that body temperature. So you do a tepid sponge, so use a warm
to cool. Yes. I've never heard of that. Anyway, I'm learning now. So the mothers, you're telling the mothers, if the child has a fever, warm cloth to maintain temperature.
Exactly. And it also, in the process of you, what you call sharing the temperature between the water and the body, you maintain the normal temperature of the body. You don't want to flip to the cold side, because there you become what we call hypothermic, and you get worse. Your body doesn't even work as well. From a child who is hot to a child who is shivering and almost cold. So that's the first thing. The other alternative is, if you are able to have what they call a first aid kit. And in the first aid kit, interestingly, paracetamol is one of the drugs that will be in such a first aid kit. And those are the ones used to keep the temperatures down as you prepare the child to move to the nearest health facility. And usually in our country, at least within 5 kilometers of where you stay, you should have a health facility. In Kampala, it could be much less. But if we look at the whole country, it's about 5 kilometers from where you live. So that's quite important.
Doctor, we are in a children's ward. You can hear the children crying. Maybe they know their president is here for their association. What can you tell, what promise do you give to children of Uganda as the president of the Pediatric Association? What can you tell them? Will it get better? Do you have plans for them to ensure they can access more health care, better trained personnel, better medicine? Your message to the children. Listen.
So, as the president of the Uganda Pediatric Association, children are our future, and all pediatricians in the country aim to ensure that we have a healthy child, because a healthy child means a healthy life. And the main aim that we look at is preventing disease and infirmity or injuries. So, breastfeeding, we talked about it. Children should be breastfed, and I'll use the
For at least 6 months.
Yes, so exclusively for 6 months. But I'll keep saying this, breast is best. So you talked about mothers who don't like the change in the shape of their breast. You are contributing to the health of your child.
They say the breast will fall. Can you assist them to put it back?
There are methods to bring it back up, but when you tell me that they don't want to wear bras, then it's a bit difficult. But breast is best, that's one. Breastfeeding exclusively for the first 6 months of life are important, but even for the first 1,000 days of life, a child should continuously breastfeed. That's up to 2 years with mixed feeding. The breast milk contains certain things that help to grow the brain of the child. So as the Pediatric Association, we promote breastfeeding as our main source, unless there's a contraindication, as Dr. Peter had said. And then as the association, we advocate for the rights of the children, protect our children at all levels. Since now we're able to breastfeed the child and the child is able to grow, we want the child to be able to strive. And then after striving, we want them to achieve. So allowing them to go through the whole continuum of their life cycle. Thank you.
Lastly, you should speak on behalf of Mulago Hospital. Sometimes there is talk around, some people have never been to Mulago, some people here, the situation is bad in Mulago, but we are right here, sitting in a ward. Some people here, there is no medicine in Mulago, but we can see there are cannulas all over, people are getting treatment. They are not doctors. I have 2 eminent doctors here. What is it that you want the people out there to know about Mulago, which maybe is misreported or a wrong perception about Mulago? How can you correct the perception?
I would first say that one, the Mulago National Referral Hospital offers a 24-hour service, and it offers highly specialized care for the children, for the adults, for the women of Uganda.
Is it for free or for cash?
In Mulago Hospital, as you will see, and what people don't want to believe, is that it is a free service for doctor care, nurse care. There are some
No paying in Mulago.
There are some services that you may have to pay for. So some imaging services, radiological services, some lab services, but generally those charges are authorized by the hospital. There is this kidogo or under the table payments, those are not,
They are not here.
Those are not authorized by the hospital. If I see a child in a general ward here, none of the parents are supposed to pay me because I am reviewing a child. That is my daily work.
You are paid by the government.
I'm paid by the government to come in and work in Mulago Hospital. So Mulago Hospital provides services for Ugandans in the National Referral Hospital and highly specialized care. And that's why we're here in the Pediatric Oncology Unit having this program.
Can you explain to the men who are watching? You have Children's Hospital, Women's Hospital. When will you open a men's hospital? Don't men have problems, health problems?
You see, the men have problems.
They have stress, they have pressure. Why don't you make for them a hospital also?
The men have problems. The men have male wards in this hospital where they are admitted for their conditions. So we don't have a specific male hospital, but we have the male wards that provide services for the male population of Uganda.
Okay, Dr. Wasswa, we are very happy that you've been able to spare time. Very busy man to be with us here, but it is as well that you have come to contribute to the understanding and awareness about healthcare and how we should avoid fakes. But I would like you to, as you conclude, help us understand. You doctors, you are special people. You take an oath, the Hippocratic oath, and in that oath, you bind yourselves to serve and treat the ill. I think the first principle is that you must not cause harm. That is what is in that oath. But every day in the newspapers, we have stories of some patients, when they don't have money, they are detained in a hospital because they have not paid their bills. Some patients die because the surgeon refused to take them to theater. Have doctors abandoned this oath, or you now have a new oath of money?
The oath, the Hippocratic oath, has been there for hundreds of years. It still exists. It's as valid as it was then as it is now. Now, doctors coming from society as we are, where society engages in activities which are not professional, which are not appropriate, again, doctors are human beings. So some of them may fall prey to those weaknesses. But I can't really speak to each individual doctor, but certainly the principles that guide professional practice are the same principles that should be applied by all doctors, certainly worth the name. Now, you taking the professional oath, training as a doctor and taking the professional oath is not a guarantee that someone will adhere to the principles, to the training to which they promised to serve humanity. And that's something that we as doctors, certainly people who are training, colleagues, are things we should try to identify, certainly among people who are training. How is their character? It's a test of character, Fred. Character. How are you a human being? Are we instilling the principles? Are we giving a good example to the people who are coming after us? Did we get a good example from people that went before us? As a human being, how are we living our lives? How do we feel about, about our fellow human beings? That comes to the core of this. Now, when you talk about certain situations like patients being detained, I think it's important that patients and families or hospitals are clear with families about what the expectations are. Okay, so that patients are not lulled into the sense of feeling that they get care and then get away, go home, and then being detained. So a lot of it is just information sharing, so people are knowing. But certainly, as a human being, if a patient came to you as a doctor, certainly to me,
will you refuse to treat because they have not paid first?
In Mulago, where I'm fortunate to work, the service is free. So patients come to us, we treat them according to their need, not ability to pay. So it's need trumps ability to pay. So that's the case certainly in Mulago, and I believe in most of the government hospitals.
So your message to the patients, to the consumers, to people out there is that if it's a private hospital, it's a business, it has got to be sustained. There are nurses, there are doctors, they have to buy medicines, so you need to pay. It's not a free service. But at the same time, the need to protect life is paramount.
Correct.
Payment can always come later.
Certainly, I believe that I'm sure all private hospitals and entities will have their own policies. But certainly, I believe what's called the Good Samaritan Act, that if somebody, by the wayside had an accident, had an emergency, and it be attended to straight away, that people in their, in their own being should be able to provide that emergency care, and perhaps transfer care onto for patients who can't afford private care, perhaps to transfer their care to somewhere else that can be provided for free for those that can't afford it. Certainly, in terms of first aid, that's a first aid thing. That's something you do on the street. That's something you do in a school. You wouldn't charge anybody for first aid. But certainly, in terms of continuing care, then this decision has to be done.
For the people watching, if your doctor is fake, if your doctor misbehaves, do you take them to the LC, to the police, or you have a body which disciplines doctors? Where do you take the errant doctors?
So all hospitals will have disciplinary policies about errant employees, including doctors. Certainly, for doctors that behave in an unprofessional way, one aspect is one way of kind of dealing with that is by communicating to their colleagues, to their superiors within the hospital. That's one way. Then there are professional bodies. We are regulated. We're regulated by the Uganda Medical and Dental Practitioners Council.
Where is it found?
They've got they're within Kampala. They have got their headquarters not far from here, actually within Mulago.
I think you can see the address on the screen. Yes,
Correct.
Uganda Medical
Dental Practitioners.
and Dental Practitioners.
Yes, okay. That is one avenue in which members of the public that feel disappointed about their care that they receive, or they think, perceive unethical behavior.
Or even to check if your doctor is genuine.
Correct.
You go to that.
Correct. And I think they have, now their platform is web-based, so you're able to check.
You can check.
Certainly if your provider is qualified.
Lastly, do nurses also take an oath? Because there are some good nurses, some nurses, you're in hospital, they take long to come and they change the drip. Some are not friendly, some are nice. Do the nurses also take an oath?
Nurses, just like all other professionals, are committed, are bound, whether they take an oath or not, are bound by certain professional ethics. And I would say that there are perceptions that some members of staff may not necessarily be as as ethical as others, and that kind of speaks again, goes back to the individual, goes back to society in general. In the same way, I would say, if you went into a shop, into a retail shop, and the person on the tiller was rude to me, and the other person was nice to me, it talks more about the individual rather than the profession. Obviously, there is a room for setting example, for setting ideals, for setting an environment that provides a stimulus for people to behave in a professional way. But also, the other thing to remember is that just like doctors, nurses have worked often in institutions which have got disciplinary procedures where their errant behavior occurs, but also they also got professional bodies to which unethical behavior can be reported. Fred, you're a lawyer, and at the end of the day is that we're also bound by certain laws and regulations within the country. Okay,
yes.
Our criminal behavior is liable to legal repercussions regardless of where it happens. Okay.
Most of us think nurses should be female, they should be ladies. So if a man comes and says he's your nurse, should you reject him? Can you have a male nurse?
The world has moved on. Many men are now entering the professions which were predominantly women-based professions. In a similar way, many women are now doctors. In fact, in some countries, you have more female medical graduates compared to men. These are traditional stereotype roles that are evolving. So in the past, women, naturally are perceived as caring, the caring professions, and nursing tends to be the ultimate caring profession. That's why in the past, women drifted mostly into nursing. But now, we're having a lot of increasingly...
So a male nurse is okay?
A male nurse is as good as a female nurse. In fact, I would say even a male midwives are now increasingly...
Male midwife?
Common.
Only in Mulago do you have male midwives? Or it's open now?
I've seen them elsewhere, but I think it's something that may catch on later.
Well, we are told that we have to end here. I can see Dr. Deogratious as a president. Presidents are always, when they get a chance to speak to their people, but for the children in this world, for the mothers in this world, Dr. Deogratious, President, Uganda Paediatricians Association, has said that the future is bright. The children of Uganda, the children of Africa, they are going to provide the best of the best. They will provide the best health care. They will make sure that they do things to do prevention, because prevention is better than cure. Dr. Wasswa, Assistant Professor, Baylor College of Medicine, but I think this is now Mulago School of Medicine, Makerere School of Medicine, I don't know. But I have had these two gentlemen here who have helped us to wind up, to close this discussion on counterfeits in the health sector. Specific emphasis has been on cancer, and the reason we have had a lot of talk about cancer is because we know so much about malaria, we know so much about HIV, we know so much about other things. We even know more now about corona than cancer. So they have been here on this journey for about 7 to 8 weeks to tap it up, to close it, and basically say the responsibility for your personal health starts with you. The responsibility starts at home. The responsibility is with the mother, is with the father, and you as the patient yourself. We have covered a wide range of topics in healthcare, in treatment. There are so many challenges that we are facing on a daily, from the kind of medicines, the kind of food we are eating, the behavior, breastfeeding, eating habits, and so on. So we would like to close this episode right here in Mulago Hospital. This hospital is more than 100 years old. We are in the oncology and hematology ward for children. You can hear them cry in the background, but they are receiving the best treatment that there is here, right here on Mulago Hill. I would like to close by saying, those who have just joined us, this is the League of the Genuine Show, the only show on the planet that covers the subjects of fakes, counterfeits, the only show that would like to ensure that you access, you buy, you consume, you use only genuine products, because counterfeits are lacking everywhere. So until next episode, this is bye from here in Mulago Hospital. See you next time.